This trial was a trial in which patients who were between the ages of 18 and 60, who had newly diagnosed AML, and who were shown to have a FLT3 mutation in their blasts prior to enrollment on the study. So this is a bit of a trick, right? We had to screen 3,300 patients around the world to find 880 about that had the FLT3 mutation, of whom about 717 were randomized to either 3+7 plus placebo, or 3+7 plus midostaurin at 50 milligrams twice a day. And patients who were randomized in induction, also that their placebo or midostaurin was carried on throughout consolidation with high-dose Ara-C, and there was also a maintenance of 12 months of midostaurin or placebo tacked on at the end of all the therapy. So it really was standard chemo plus or minus midostaurin or placebo. So this met its primary endpoint. The trial was positive for survival in those who were randomized to midostaurin. There was a 23% reduction in the risk of dying if you were randomized to the midostaurin arm. It was quite amazing. There are a couple of things. One, it was a positive survival advantage in all the subgroups that were looked at, well, all the FLT3 subgroups. So FLT3 comes in two flavors. It comes in a internal tandem duplication mutation, which is a length mutation in the juxtamembrane domain. That occurs in about 25% of AML patients. And there's another flavor called the tyrosine kinase domain mutation, which is a point mutation in the tyrosine kinase domain that occurs in about 10% of AML patients. So altogether it makes up about 35%. And there's actually two subflavors of the ITD. There's the ones that have a high level of the mutant allele, and the ones that have a low level of mutant allele. Those low ones probably FLT3 may not be that important in their disease. Anyway, all those groups were balanced in the trial, and all those groups benefited from midostaurin, which tells you, number one, that it may not have to do with FLT3 completely. If it worked on the low FLT3 ITD patients, maybe it's going to work in a wider spectrum of AML patients, because midostaurin is not just a FLT3 inhibitor. It inhibits a number of other things like protein kinase C, c-KIT, and VEGFR, which may be important in AML pathophysiology.